So imagine a woman who wants to see a doctor, but she cannot. Now imagine a pregnant woman with 8 months of pregnancy, and she's suffering from the urinary tract infection, and she's in pain and discomfort. And community health workers said again and again that you need to go and attend antenatal care service. And she hasn't gone. My question is, if the health service is available, exists, if the health centers are nearby, if all the informations are available, why do some women still don't use them? And I need to ask this question, who decides when a woman receives a health care? I would like to share a story of Sarita. I met her when I was in India, when I was conducting the research on antenatal care utilization services in India among the pregnant women. So Sarita, she is a 23 years old woman, and she is actually a newly married. When she was actually, when I was talking about her, she was a pregnant woman of 8 months old. Community health worker said that, okay, you need to go and attend antenatal healthcare service because you are in a dire need. And she was like, okay, let me ask a family. About her pain and discomfort, she actually went and asked about her husband. And she shared, and she said, this is what I'm going through. And husband said, this doesn't seem to be important. It's not urgent. Maybe you can go later. When she went to her mother-in-law said, this is not important. We have gone through the same thing. The pregnant women usually go through all this thing. This is something not different. So you are not different. After hearing that story, I was like, what's actually happening here? And she actually kept quiet and suffered in silence. When I asked about what exactly happened, she was like, she was asking for a permission to go and see the medical doctor, the permission to ask for like what she can actually do. But what actually happened, she didn't receive it. It's not like that she was not aware about the fact that antenatal care was going to help her in a way. She was aware about it. She was having all the information. And she was aware about where the health center is. But what she was looking for is the permission, which she didn't receive from her family members. It's not that Sarita's story is the only story we know about. There are millions of women who are actually going through the similar thing. They are being caught up because of the household chores. They're caught up in their caregiver roles. They're caught up in their cultural expectations, which is to be a good woman. So when I need to talk about the health autonomy is not about that they need to receive access or they need to have an access to health services, but it is more about making a decision about their own health, a decision about their own care, the decision about that they need to go and seek the health services without any restrictions. And what was happening with Sarita, that she didn't miss the antenatal healthcare services because she didn't care about her health, but because her health was not hers to decide. When she actually missed, it was more about her health autonomy got blocked because of the household chores, because of the cultural expectations. In public health, when I need to talk about the delays, there are 3 delays when we look at. The delay 1 is the delay in the seeking care. The second one, delay in reaching care. And the third one, delay in receiving care. When we look at the health autonomy, it's sitting at the top, which is delay in the seeking care. So far, for the decades, we have been focusing on building more hospitals, building more clinics, building more programs. But what we need to do is, we need to look at the barrier. So barrier here is not about the absence of services. It's about the absence of power to decide like when to receive the care. When I'm talking about the power is related to the consent. The power is related to that to be heard, that they need to be taking care of themselves as well. And why it matters in maternal health, because she is not deciding for herself at the moment. She is also deciding for the unborn child, because it is about the next generation which is coming up. If I'll talk about the stats, according to the World Health Organization, approximately 800 women die every day because of the preventable pregnancy-related causes. I'm emphasizing on preventable because that could have been prevented. Those are the medical, those are the clinical, but we also need to focus on this is also related to a health-seeking behavior. When I'm talking about these women, these are not just the numbers. They represent mothers, daughters, sisters whose voice were silent. And when we are looking at the barriers, those are the structural barriers and the systematic barriers we usually look at. The barriers like that, yes, there is a weak infrastructure, poverty, or a distance. But what we need to basically look at, who's actually giving her the permission? Who's deciding the health for her? So about the decision, when we look at beneath the decision making, we have the patriarchal norms and we have the power systems who quietly undermines a person's ability to choose a voice and act. The patriarchy, if I'll say, is not loud. It works quietly. It works quietly in the terms of norms. It works quietly in the terms of roles, responsibilities, or cultural expectations. That women are supposed to be doing this, women are supposed to be working like that. So there are norms and working silently. According to the data from the Social Institution Gender Index data, 57% of the women made, globally, 57% of the women made a decision about the contraceptive use, the sexual relations, and then the reproductive health care. 57%, but now my focus is on what about those 43% when we are looking at. Because when we are looking at the health autonomy, it is not a luxury, it is actually the foundation of health. Because if women lacks autonomy, it is more about the health-seeking behavior become more negotiable. Negotiated with the family members, maybe with the husbands, maybe with the mother-in-laws, and then a wider community. One of the barriers which we rarely talk about and rarely appear in the policy document is the time. When we talk about the time, there is a data from a UN Women data talking about the women and the girls do 16 billion hours of unpaid care work. When I'm talking about the unpaid care work, those are the invisible work. Invisible work in the terms of that they are cooking, cleaning, taking care of the children, taking care of the elderly, family members, and silently running the economies of the families. And this is 2.5 times more than the men. And it's not like that this is only the data. In some regions, it is more than 3 times, and in some regions, it's more than 4 times as well. So it actually creates a time poverty. So my question is, if the woman is not having time for her own health, how she will going to seek the healthcare system that we have created for her? So many of the women, they usually ask themselves, if we're going to go and seek the care out, who will going to take care of the family? So it is not about the health autonomy is actually being rebellious. It's not about being a selfish, but it is actually the foundation of health. Thinking about the foundation as a house. You have a home, you have the foundation of a health autonomy. But if it is weak, how this house will going to stay? So when we are looking at the health autonomy, when others decide for women, the health autonomy actually disappears. Same as with Sarita, because she was having all the thoughts in her mind, and she gave that power to someone else to decide for her. So basically, what we can actually do, how we can actually address these challenges. So we need to rethink about the women's health. I have listed out some of the innovative ideas. I call it innovative ideas, but yes, this is what we can actually look at. So the first one could be about measure women's health autonomy. It has been understandable that if we don't measure something, we don't change it. We measure attendance, we measure outcome, we actually measure everything, the health indicators, but we don't measure women's autonomy. So what if we start measuring that who is deciding for you, whether your decision was voluntary, where do you want to go and seek the health care? If we can start asking these questions. There are some of the scales which are available, like in the UK, we have a reproductive autonomy scale, which is RAS, and then we have RAI, which is Relative Autonomy Index. We could use that, but globally we don't have as such like a tool to measure autonomy, so we can actually look at that. Second is about we need to recognize unpaid care work, fight time poverty. We need to build a health system around the woman's reality. If they don't have time, yes, they won't be able to attend. What we can actually do is to work around the woman's reality. For example, we can look at a flexible appointments for the woman. We could also look at the community-based care. We can also look at the childcare-friendly services for the woman, if it is available, along the time while we are working on the other things. Also, about the early life autonomy education. If we want empowerment to last and sustain, we need to start early. Looking at Sarita's story, if she would have aware about that her voice actually matters, she would have sought the healthcare services way early. So if we want the girls or women to actually understand that their voice matters, we need to start early in the early space. The next one is change community norms. I understand that you all are thinking that how we can change the community norms in one day. Actually, we cannot, but we all can work together to actually work towards it. Because it's not a one-day work, but we need to understand that women is not living in isolation. Women is actually living along with the community, with the family, husbands, and then the elderly members. So if we are engaging them in the health interventions, we would be able to involve them and could change something which is actually helpful for women. Then about the women-led community health councils. So a representation in the council for health. It is not about representation here is not symbolic, but it is more about a life-saving. Women, the need that we are looking at, rather than looking at the assumptions, we can basically looking at the real need which is required for the community and for the women. So if we have those women involved, we would be able to get a more clarity. Then about the leveraging technology, we can actually use some of the technology not to weaken the empowerment, not to restrain it, but to actually support it. In the terms of, we could use, for example, a mobile health apps, a teleconsultations we could use, and we can also have a kind of reminders for women. So we are basically looking at the women, they are having a resilience in their own hand, looking at where they can go, what they can do, and how they are working on it. Engaging husband in the health decisions. It has been seen from the low and the middle income countries that pregnancy or the health-related issues of women are mostly being seen as something different than men. They don't engage, they usually disengage. And also the mother-in-laws, they usually disengage from the decisions about it. So what we could do is that we can involve them in the health intervention, and we can ask them, okay, if you are there, how you can actually support the women in this. So we want to engage husbands and also our mother-in-laws. Last thing is about building a system that supports women's independent healthcare access. If we can actually build a health system where women can go independently, without waiting for the permission, without waiting for the justification, without waiting for someone to accompany with, if we can build that kind of a system, women won't be needing the permission. which society is seeking. So if we can build that, yes, we would be able to have that women autonomy. So I just want to leave with the question here. When we are looking at the health system, what type of health system we are looking for? The one which actually serves the woman, or the one who's actually waiting for women to get fit in? Empowerment is not something like that we want women to have a voice. They already have one. The only thing that we are looking at to remove that permission that society is kept on seeking. We need to have a healthy society, because that's not beginning in the hospitals or in the clinic, but it begins the moment a woman no longer needs permission to care for her own body. Thank you.